So, malignant hyperthermia is a hypermetabolic crisis. Okay? So the uh, muscle contraction and the increased BMR or the metabolic state. Temperature is increased because the BMR increases because of the violent muscle contraction, and it is stimulated by the volatile anesthetic agents like halothane, sevoflurane, isoflurane, and desflurane. It can happen in all ethnic groups. And it is more common in males than females, 2:1 ratio. And children under 19 years account for 45 to 52% of reported events. Now, pathophysiology, there is a genetic skeletal muscle receptor abnormality with excessive myoplasmic calcium accumulation in the presence of certain anesthetic triggering agents. In normal muscle physiology, what happens? A depolarization spreads throughout the muscle via the transverse tubule system. It's called the T-tubule, which activates what is called the dihydropyridine receptor located within the tubule membrane. These receptors are coupled to nynodine receptors, which regulate the passage of calcium from the sarcoplasmic reticulum into the intracellular space. Now, this calcium combines with troponin to cross-link actin myosin, resulting in muscle cell contraction. And once the trigger is over, what happens? The calcium gets detached from the troponin, and then it is taken back into the sarcoplasmic reticulum by the calcium ATPase pump, which results in muscle relaxation. So for every trigger, first calcium goes, activates the actin myosin complex by attaching itself to troponin. Then this detachment occurs between calcium and troponin. Calcium goes back its original place of sarcoplasmic end of reticulum. This does not happen in malignant hyperthermia. And more calcium gets released through the endoplasmic reticulum. So the mutations encoding the abnormal ryanodine receptors or the dihydropyridine receptors have been found in majority of malignant hyperthermia syndrome patients, which exposure a triggering agent in these patients lead to unregulated passage of calcium from the sarcoplasmic reticulum. So instead of closing down to prevent further release of calcium after one stimulus, the gate is kept open so that more and more calcium escapes from the sarcoplasmic reticulum into the intracellular space and goes on stimulating more and more troponin and keeps the actin myosin complex always in a coupled state. Doesn't allow the relaxation to happen. That is why the muscle rigidity happens, and this triggers the basic metabolic rate and causes the production of heat, which results in hyperthermia. So this is the mechanism, and these pictures will give you a very good idea about. Here, this is the T-tubule. This is the mutated ryanodine receptor. This is the dihydropyridine receptor, and this is the sarcoplasmic reticulum. So the calcium is stored in this. So what happens? There is a first triggering substance comes here, and so the passage of calcium coming out from the sarcoplasmic reticulum is guarded by this ryanodine receptor. So it is in a closed state now here. Once the triggering substance like volatile anesthetic or hexamethonium is coming there, then what happens? The gate opens and then it goes on allowing the calcium to come into the sarcoplasm, simulating the series of events. And in patients with this mutated ryanodine receptor, this does not go back to this first closing stage. Whereas in a normal healthy person, after it opens and a few calcium ions come out, the gate will close and shut the further extrusion of calcium from the sarcoplasmic reticulum. And once the calcium has finished its activity of triggering actin myosin coupling, and it gets detached from the troponin, again it will come back and be taken up into the sarcoplasmic reticulum. So that does not happen in the patients with malignant hyperthermia. And this function of blocking this channel of calcium extrusion is done by dantrolene. So dantrolene, what it does is it replaces the action of this ryanodine, mutated ryanodine receptor by going and sitting in this area. So that is how the whole thing acts. And these are all other pictures how the depolarization acts and the calcium coming out. You can see this is the malignant hyperthermia triggers, sustained muscular activity, muscle red cell metabolism increases. So there is enhanced oxygen consumption, excessive carbon dioxide and heat production. So this results in the crisis, which causes muscle rigidity, hypercapnia, hypoxemia, acidosis, and because of the constant contraction, rhabdomyolysis, which also causes the release of potassium from inside the cell, resulting in hyperkalemia and hyperthermia. So all these 7 things you have to, the things that happen, the pathophysiology produces this. So these are the things that you can have evidence of hyperkalemia in the form of ECG changes, and you can have acidosis and production of lactate, which will suppress all your enzyme activity. That is why if you don't treat it in adequate time, the multi-organ failure can result. And, so over the time, the sustained hypermetabolic activity causes not able to dissipate the heat and aggravated by cutaneous vasoconstriction. Hyperthermia may occur early or may be delayed following the initial symptoms. And the core temperature rises 1 degree every few minutes. That is how the temperature goes on. So even if the patient is anesthetized in a very cold ambient temperature, the core temperature is the one which will be going on raising, and it may reach as much as 41.5 degrees centigrade or 106.7 Fahrenheit within a few minutes. And the worst prognosis is identified by the patient developing disseminated intravascular coagulation. So from whichever puncture site or operative site, if the patient starts oozing a lot, that indicates that the prognosis is poor, because that is a terminal event that happens. So the only therapy is dantrolene, which binds to the ryanodine receptor to inhibit the release or leak of calcium, and this reverses the negative cascade effects. And it requires the presence of the other enzyme called palmodulin and sufficient magnesium. These two are very important for a proper functioning of the dantrolene. And increased arthronormal influx of calcium via TRPC 6G and TRPC cationic channels is as important as dysregulated. So it is not only the calcium extruding out from the sarcoplasmic into the cytoplasm, it should be taken back also. Otherwise, just by closing this, you will not be achieving the desired effect. So the calcium has to go back into the sarcoplasmic reticulum, which occurs through what is the TRPC? Krisha, what is the expansion of this TRPC? Transient receptor protein complex 6. Okay, that is a receptor that a cationic channel, through which only the leaked calcium has to go back. So that also has to function. So the threshold for SR calcium overload induced calcium release is lower in malignant hyperthermia patients, which further lowered by inhalation anesthetic agent. So for a proper functioning of dantrolene, 2 things are important. One is there should be adequate presence of palmodulin and magnesium. Second is the reuptake of calcium into the sarcoplasmic through this TRPC6 and TRPC3 channels should be quite patent and should be functional. Only then dantrolene will be able to act well. And increased mitochondrial calcium produces a lot of reactive oxygen species, which also increase the SR calcium leak. That is another part. Apart from the mutation of the ryanodine receptor, this another small mechanism is free radicals, which also are responsible for increased calcium leak. So succinylcholine, being analog of acetylcholine, stimulates the motor end plate to initiate muscle repolarization, and this gets prolonged in these patients with malignant hyperthermia syndrome. And it may also cause generalized muscle rigidity or muscle spasm at the beginning of the anesthesia as soon as the drug is given. Now, what are the clinical features of that? Because everything has been nicely described by Risha. So, sequence and timing are variable. It is not the same. Some patients may get changes within a few minutes. Some patients may take half an hour or 1 hour. Or I have the case which I saw. It happened after almost about 3 hours of anesthesia, and some cases will appear within minutes of after cessation. Some cases may be indolent and others may be accelerated. So the presentation is very, very variable. The clinical signs are most reliable are unexplained increase in EtCO2. That is the first and foremost warning sign. Then if the patient comes out of the relaxant, even if you are doing controlled ventilation with non-dipole muscle relaxant, patient comes out of it, and when they come out, their respiratory rate is very high because they want to eliminate the carbon dioxide that has been produced. So their respiratory attempts will be much more faster, and they will be breathing over the ventilator set rate. Despite the minute ventilation, that would be maintain normocardia. So even if you are delivering adequate ventilation, patient will try to hyperventilate himself. And in size of acute MH, there will be sinus tachycardia, rigidity, even in the presence of non-depolarizing muscle relaxant. And very rarely you may have features of hyperkalemia, such as peak P waves or disappearance of P waves, QRS widening. All the features of hyperkalemia will be there in the ECG. And clinical features: hypercarbia, generalized rigidity, muscle rigidity, arrhythmias, hyperthermia, myoglobinuria. Laboratory findings: there may be ABG will show a mixed metabolic and respiratory acidosis. There may be hyperkalemia, elevated kinase and myoglobinuria, and lastly, disseminated intravascular coagulation. The other differential diagnoses are anesthesia and surgery related, insufficient anesthesia and analgesia, hypoventilation or CO2 rebreathing also sometimes mimic the same syndrome. Increased carbon dioxide during laparoscopy and GA endoscopy, and fever. Other causes are sepsis, anaphylaxis, anesthesia-induced rhabdomyolysis, thyrotoxicosis also is another possible etiology for this increasing temperature alone. And transfusion reaction, drug abuse, serotonin syndrome, pheochromocytoma, neural malignant syndrome, or baclofen withdrawal, or following hypoxic brain injury or hypothalamic injury. In cases of head injury also, this clinical picture can happen, but that is not a mutated ryanodine receptor. It is not the classical malignant hyperthermia, but the clinical features of hyperthermia, hypercarbia, tachycardia, all these things will be mimicking the same clinical situation. And that management, you can divide into acute management. Initial steps: call for help and malignant hyperthermia attack, notify surgeon, optimize oxygenation and ventilation, discontinue triggering agent, administer dantrolene, and laboratory and maintenance treatment, treat the hyperkalemia, treat the metabolic acidosis, then cool the patient, reduce the temperature as much as possible by surface application, intragastric, intrabladder, IV fluid cooling, or sometimes they have gone up to the essence of ECMO also. Extracorporeal membrane oximeter may be required in very resistant cases where temperature is not coming out, and monitor urine out for, because AKA, acute kidney injury, is very, very important thing which can cause the mortality. Okay, so these are all the things that you have to remember for malignant hyperthermia. If you remember that picture that I showed you, then it is very easy to understand how the whole pathophysiology happens in these patients. Okay?
Yes, sir.
Right.